Well, warm welcome to today's talk. It's Wednesday, the 1st of February. Now, we now know that vitamin D supplementation provides substantial benefit in terms of reducing the risk of admission to intensive care during the coronavirus pandemic. 72% is the probable figure, certainly substantial. And it probably also gives us a 51% protection against death, vitamin D supplementation. Now, on this channel, we've been talking about vitamin D since we started the channel in 2007, a long time ago now, and we've been talking about it throughout the COVID pandemic period of time. Now we have this new meta-analysis from Italy, definite protection against admission to intensive care for patients that are ill or hospitalised. I now believe it's unethical for authorising bodies, Medicines and Healthcare Regulatory Authority and FDA and people like this around the world, not to advise vitamin D supplementation for poorly people and arguably for the whole population. I believe it's now unethical that they don't do that, but they're not doing that. They are recommending treatments that are less efficacious, but they're not recommending vitamin D. And vitamin D is safe and effective. We've got to be careful how we use the term safe, but vitamin D is about as safe as cabbage or eating anything else. It's just a nutrient, but we get it from the sunshine. That's why we're short of it. We're short of it in the Northern Hemisphere over winter because we don't get it from the sun. That's why we need to supplement it. Personally, at the moment, I'm taking 4,000 units of vitamin D a day. That's 100 micrograms. And I take that in combination with 100 micrograms of vitamin K2 as well.
Thank you, John Campbell, for yet another clear and concise presentation on the incredible safety and efficacy of what we in the US call vitamin D. And by the way, it's August now, August the 16th to be exact. And this is still an incredibly powerful and effective nutraceutical. And it is, it's what our doctors in the FLCCC Alliance have used in their practices for years. And in so many of the protocols, the prevention and treatment protocols for COVID through this pandemic. Well, why? Well, because they know from their own experience and from reading reliable scientific studies how it works to fight a variety of ailments and to promote good health. It made absolutely no sense that public health agencies, if they're really working for public health, did not promote the use of vitamin D from the very beginning of the pandemic. So welcome to the FLCCC Weekly Update. I'm Betsy Ashton. I'm creative director of this alliance of doctors and scientists and patients who we've helped and other people who are supporting us. And tonight, you're going to find out why you want to remember to take this little capsule. It's just this little thing right there. You want to remember why it is so important. Our guest is a doctor and an MD, a PhD, a professor of medicine who is a recognized global expert in the fields of endocrinology, internal medicine, osteoporosis, bone diseases, kidney diseases, and nutrition, as well as vitamin D. And if I read all of his credentials, it would take up the entire hour. So I'm not going to do that. But I want you to meet Dr. Sunil WImalawansa. He is going to share his knowledge about vitamin D with us and our own medical expert, Dr. Paul Marik, and I will be back with questions, your questions and some of mine for them after their conversation. But our nurses are already online to answer questions that you post in Q&A. So welcome, Dr. WImalawansa. We are delighted to finally get you here. And take it away. Please tell us, you and Paul, what we need to know.
Thank you, Betsy, and also Paul for doing a fantastic job over the past almost 3 years now, helping the community and the world, basically. Have been very helpful. Now,
so yeah, we're so grateful that you were able to join us today, Sunil, because your guidance has been instrumental in helping us formulate our plan for vitamin D. And just for the listeners, that Sunil does have a little bit of a throat issue, so he sounds a little bit hoarse. But we hope this will be reversible pretty soon. And we thank you for being here. So Sunil's going to start off with a PowerPoint presentation. He's going to walk through us, and then we'll have a discussion. And I can't think of a more important topic than vitamin D. And as Sunil will probably tell us, it's actually not a vitamin. It's a hormone. It's probably one of the most important hormones in the body. And I think we're in for a treat tonight. So thank you, Sunil.
Thank you, Paul. And let me start with the PowerPoint. And so over the past 3 years, we had the opportunity to learn a lot more about vitamin D and its relationship with the immune system, thanks to indirectly to the infection and the pandemic. There have been a lot of new information derived over the past 3 years. Unfortunately, many have been kind of downgraded to obvious reasons of other issues. So what I'm going to do today is to discuss the key concepts related to vitamin D and how its biology and physiology relating to the immune system, and particularly the modulating the immune system. And then I'm going to move into the importance of vitamin D and calcifidiol, which is a partially activated vitamin D, has a tremendous benefit in acutely ill patient. Nothing works as good as calcifidiol in saving life on somebody really severely ill with infectious diseases. Of course, in addition to the other ongoing standard therapy, in the case of bacterial infection, antibiotic, etc. So here are the fundamentals of vitamin D as we know now. The USA and Europe, the D3 is considered as a dietary nutrient supplement. Nevertheless, there are some countries it is not the case. I remember that 2 years ago, December, the New Zealand Health Department had an initiative, in fact, a serious initiative and a policy to medicinalize the vitamin D so that they can control the prescription and the payment and all this stuff, just all about the control, nothing more than that, as zero benefit. I don't know what happened. Eventually, many of us wrote against that, doing so. So 50,000 international unit is the highest commercially available vitamin D dose. And vitamin D has a wider therapeutic index. It has a broader benefit. It's globally available at a very economical cost. So it's a very stable shelf life, and it has no known adverse effects with other medications. So here's what happened with the vitamin D, whether you take it, whether you generate from the skin or take it orally. Vitamin D will be hydroxylated in the liver to form 25-hydroxyvitamin D here. And then in the kidney, and most very importantly, peripheral target tissues like immune cells, it also converted the second hydroxylation at alpha 1 position. So this is a final product of calcitriol. As Paul mentioned, the part of that is a hormonal form, but the more important part is a non-hormonal form of calcitriol. So as I said, whether it's a supplement or generated through the ultraviolet B rays between 285 and 310 nanometers, or as a diet, like in mushroom, for example, it has to convert it in the liver to form vitamin D. Therefore, there is a delay of 1 to 2 days, or in most cases 3 days before 25-hydroxy D actually enters the circulation. So this delay is very important for acutely ill patient that's unjustifiably delayed. That's why the calcifidiol become important, because bypassing all these steps, you are actually giving 25-hydroxyvitamin D directly into the circulation, even though orally, because it's absorbed within 4 hours from the GI tract directly into the bloodstream, unlike vitamin D actually go through the lymphatic system, through the chylomicron system. So there's another delay of 1 day of when you go vitamin. So 25-hydroxy, when you give as the calcifidiol, directly increases the circulating vitamin D. Now it has 2 options. One is a hormonal calcitonin, which is produced on the renal proximal tubular cells and then entered into the circulation. So by definition, it produced in one place and acting on another place. So it's a hormone, this portion of calcitriol. So it's predominantly involved in the calcium homeostasis, bone metabolism, bone calcification, and indeed the parathyroid functions. So all the musculoskeletal system. On the other hand, on the non-hormonal calcitriol are produced within the target cells. To do that, you need to get 25-hydroxyvitamin D directly inside these key cells, like immune cell. Imagine immune cell waiting for 25-hydroxy D to produce calcitriol. So the level has to be right for it to diffuse into immune cell, because an immune cell does not have an active transportation system, unlike muscles, renal tubular cells, and the fat cell has got a thing called myelin-tubulin active system to extract vitamin D from the blood into their cells. But non-peripheral target cell does not have that. So they are purely depending on the concentration of vitamin D and 25-hydroxy D concentration to getting into the cells, so that they can have a genomic and non-genomic actions like a membrane and autocrine paracrine system, like in immune cells, to continue with their function. A couple of hours ago, I read this beautiful article by Vitamin D, Nature's Sun-kissed Superhero. I thought of putting the web link here from the FLCCC, which is a very timely executive summary. I suggest that people go and read that leisurely. So in vitamin D deficiency, it's increased microbial infection, viral and bacterial particularly, increase of cancer and autoimmunity, metabolic disorders, non-traumatic acute disorder. There are many of them get started and worsened by vitamin D deficiency. Chronic diseases, musculoskeletal disorder, that's what we knew for several decades. And indeed, it harmed the pregnancy and the infant and the growth. There are 6 key factors that influence in the vitamin D level. First is the sun-avoidant behavior, partly due to dermatological scares or skin cancer, etc., and looks of some people, particularly the Asians, who doesn't like to get their skin darker, so they avoid sun and use too much sun blocker. Secondly, the more important to us is actually UV-based rays are not effective during the winter. They're coming in the wrong angle and it does not penetrate the dermis to generate vitamin D. So third is the excess body fat. It not only sequesters the vitamin D, but also increases the catabolism of vitamin D. So those with obesity have a consistently lower vitamin D and requiring 4 to 6-fold higher doses to maintain their vitamin D level. Next one is taking medication like retroviral medication and the anti-epileptic agents, which can increase the catabolism of vitamin D. So those people also need a higher dose of vitamin D to maintain. Fourthly, the melanin content of the skin tone. The higher the melanin content, lesser the amount of vitamin D produced in the skin. So people like myself had to stay longer in the sunshine compared to Paul, Dr. Merrick, because my skin, melanin will actually filter UVB rays. And finally, the age. Higher the age, lesser the effectiveness of the producing the vitamin D in the skin. However, having said that, there is a three ways of producing vitamin D. One is a sensible daily exposure. Second is the supplementation with vitamin D and other micronutrients. And finally, the targeted food fortification program. All are important to maintain the vitamin D content in our circulation. Now, daily exposure up to 1 hour is necessary to generate sufficient vitamin D in most patients, most people. How so this slide basically shows so we're taking the calendar months here on the x-axis, and here what you see is a mean serum 25 concentration in the y-axis. So what you're seeing here is during the winter period, there's a consistently low vitamin D level. In fact, in the US, 80% of the population are vitamin deficient during this period. And in fact, during the summertime also, 30% of the population are vitamin D deficient. Now, this annual flu season, not surprisingly, coincides with this low vitamin D period. And also, as you show in the next two slides, indeed, it coincides with the COVID-19 outbreaks we had for the past 3 years. And reason is pretty obvious due to community vitamin D deficiency. Now, this is a slide from Our World in Data, the database, and it's freely available in the internet. But when you look at it, this is a number of hospitalization COVID-19 per million. It's like a shadow box all over the place. However, when you overlay with the winter period, you begin to see the specific peaks coming from November to about March every year. This is very common with the flu, influenza, etc. And again, the next one is introduction of COVID vaccine of end of 2020. Despite claims, it really didn't show any impact on the reduction of cases or the death as shown in the next slide. Now, here's the same data on the top panel. We're looking at the number of hospitalized COVID-19 per million persons. The bottom is the number of deaths per 7-day average. So the denominator is a little different. But when you overlap with the winter periods, you can see whether it's cases or deaths. It does increase dramatically during the winter period, which coincide with the low vitamin D in the community. I said that in the US, 80% of the population are vitamin D deficient during this particular period. So this really made a case about vitamin D to start with, but we knew that from January 2020 on this issue. And let me show you two slides related to the previous slide. First one is a percentage of people who completed the COVID vaccination on this axis, and the time on the x-axis. If you look at this, unfortunately, I don't know if you can see the behind it. These are all affluent countries, Western countries, except that Japan and Australia included here. They had a 70% of the population vaccinated. Compared to developing countries on the bottom part, they had only 15% get vaccinated. I'll show in the couple of slides later, this is exactly the opposite of the cases and the death. It's completely upside down. The next one is the percentage of people who had COVID booster doses. And again, the similar countries, affluent countries versus the developing countries here. And 70% of the people in these countries by early 2023 had booster doses. But only 5% of the countries, developing countries, had the booster doses. In fact, some countries had zero. Now, again, I don't know whether you can see the panel behind this, the right side panel. These are the countries who had the highest vaccination rate. And here there's some examples of countries with the lowest vaccination rate. And these guys on the bottom had a 1,000-fold difference of deaths and cases. Why? Because this upper panel had a 70% vaccination, lower panel had a 5 to 15% vaccination. Still, the people in the developing countries, most of them are within 1,000 miles from the equator, where the sunshine is there, had a 1,000-fold, not percent, low death incidence. By the way, this is on log scale. You can see the difference. Now, during the past 3 years, we, the people, have been asking for help from the agencies and the government, which did not come forward with the help what we were looking for. Regulators, agencies, and the government were creating issues rather than helping us, as most of you know, by now, as the previous short video, you can show that Dr. Campbell was saying that, look, at least now they should open their eyes. All right. Dr. Marek had a fantastic presentation about a month ago on vitamin D and cancer. I'm just adding only 2 slides just to highlight a couple of areas. Firstly, vitamin D has such a significant negative effect on all cancers, although only part of some cancers had been shown to dramatically get affected. That's because of less power of the studies and not enough duration there are studies. But it has a main effect on the preventing the chronic inflammation, oxidative stress, and stopping or dampening angiogenesis, so that not only cancer cell growth will be suppressed, but also dissemination or metastasis will be suppressed. Secondly, it also affects the metabolism of cells, including the glycolysis. As Dr. Marek said in his presentation, it also complements to the fasting regime to starve this cancer cell, because they're depending on the glucose surges. And thirdly, the most important thing in this particular 2 slide is vitamin D suppresses synthesis and formation of the NF-kappa B, which is a cytokine, which causes exactly the opposite of what we want with reference to the cancer. It increases the cancer cell growth, it disseminates them, cell proliferation, metastasis. Now, why that is important? Because NF-kappa B, while in excess of NF-kappa B increases inflammation, anti-apoptic, and it also increases glycolysis. So all are favorable for cancer growth. In addition, lastly, NF-kappa B also produces the mutations in the most important cancer gene in our body, which is the p53 gene. So if the p53 get mutated through the NF-kappa B in those with a severe vitamin D deficiency over a period, they are very likely to develop cancer in their lifetime compared to those with the vitamin D sufficiency. So let's look more into looking at the key functions of vitamin D. Firstly, today's topic, we are talking about enhancement of the immune system, reduce inflammation, and reduce oxidation. Those are the 3 most important things in infection point of view. In addition, vitamin D does a lot of other things, is protect the DNA and enhance its repair, reduce autoimmunity, improve mitochondrial functions, therefore the energy metabolism. So this is really important and completely neglected area for various chronic inflammatory diseases. This become very important. And also it's improve the cellular function in general. Let's move on to the vitamin D and the immune system, which is a key area of today's presentation. So as I said, both D3 and 25-hydroxy-D from blood diffuse into the immune cells. There are also things called endocytosis happening, but mostly this enters the immune cell via the gradient. So to happen that serum or the blood concentration of D3 and 25-hydroxy-D should be higher than the immune cell cytoplasm. So that's where the increasing level of serum level of 25-hydroxy-D has become crucially important. That's a fundamental behind it. So once the calcitriol is produced within the immune cell, it activates the genomic and this non-genomic function like autocrine and paracrine functions, very beneficial and essential for immune cell function. So calcitriol not only boosts the immune system, then immune system now control the pathogens because it acts on the innate and acquired immune system, which I will elaborate a little bit later. So this will allow the immune system to control the viruses, COVID-19, or SARS-CoV-2, as well as bacterial infection, particularly intracellular bacteria like Mycobacterium tuberculosis. In the absence of vitamin D, most of the TB patient actually died. But a century ago, that's what happened. That's the time we took the patient out during the daytime, the sunshine, and they saw that the beneficial effect of staying in the sun. Those who went out survived, and those who didn't died quickly. So this prevented microvascular thrombosis, as well as the ARDS and the pneumonia, and even more importantly, immune cells can prevent this cytokine storm. So these three are the commonest reason of death from SARS-CoV-2 virus. So when you have the vitamin D sufficiency, they do not develop severe complications and they recover fast. Now, this slide I throw because to show the key mechanism of action of vitamin D, again to strengthen the importance of circulatory 25-hydroxy vitamin D. Now, we discussed that in the kidney renal tubular cells, it produces hormone calcitriol. However, it has virtually zero effect on the immune system. Most physicians forget that, and maybe they're getting confused with the hormonal form. Hormonal form has a very little or no effect on immune system. Why? It comes about 1,000-fold less concentration into the circulation in picomolar compared to the nanomolar concentration with the 25-hydroxy vitamin D. So there's a huge difference of the concentration gradient, and this is not even touched across the cell membrane. This is too little. So this is also important, but giving calcitriol exogenously to ill patient with infection, hoping for them to get better, is an illusion. It actually makes it worse. So calcitriol should not be administered in the acute ill patients as a treatment regime. So right way is actually to give the vitamin D and calcifidiol so that it can produce intracellular calcitriol within these immune cells that can actually interfere or modulate all the immune cells and their good actions. So I know that there are a few scientists participating in today's seminar. Therefore, I put about 2 or 3 more scientific kind of slides to keep them entertained. Now, this particular slide summarizes the huge amount of data related to vitamin D and renin, angiotensin, aldosterone axis or system. And I'm also showing that how it screwed up or interfered by SARS-CoV. In fact, it's actually hijacked the entire system. So angiotensinogen is produced within the renal cortex, the system, which we break down to angiotensin 1 by renin, that's rate limiting step, and then to angiotensin 2 by the ACE inhibitor, ACE angiotensin converted enzyme 1. Excess angiotensin 2 is, in addition to being the potent vasoconstrictor, it also increases inflammation, increases pulmonary hypertension, coagulation, and all the bad things happen with the excess angiotensin 2. So we have a built-in system in the body to prevent that happening in the balance. The balance is actually a thing called ACE2, angiotensin converting enzyme 2, which break down angiotensin to angiotensinogen 1 to 7, is exactly the opposite effect of angiotensin 2. So it counteracts all the bad things and prevent we are getting sick. So in the absence of that, excess of angiotensin 2 lead to all these negative things and lead to cytokine storm, ARDS, and other complications. So having adequate amount of calcitriol, it does several things. Firstly, it reduces the synthesis of renin and ACE1. Therefore, less amount of angiotensin is produced. So naturally, there won't be any negative bad outcomes. So in the absence, you can imagine that excess is exactly opposite thing happen and you end up with here. Calcitriol also increases the synthesis of ACE2, which is a good thing, which actually reduces the viability of the SARS-CoV virus in circulation. It actually removes from the circulation and prevent multiplication. So in the absence of, so it also produce the opposite of angiotensin 2 by reducing the inflammation, vasodilatation, normotension, and reducing apoptosis. Now, here's the trick. when the SARS-CoV-2 virus SARS-CoV-2 virus appears, it actually hijacks the ACE2. It actually not only reduces the production of ACE2, it also prevents its action. Therefore, instead of getting all the beneficial effects, the RAS action, renin-angiotensin system action actually push more angiotensin II, causing all the problems associated with COVID. It's another slide I put up for the benefit of people who are deeply into this area, where the vitamin D has, as I said, is a potent inhibitor of NF-kappa B. So CD4 immune cells, depending on NF-kappa B, to their immune function, mostly to have a balance between inflammation and non-inflammation. So vitamin D is a promoter from inflammatory Th1 cell into Th2 cells. These are immune cells. And also it inhibits the Th17 cell and converts them to beneficial T regulatory cell. So what happens is eventually is it's from the inflammation, it convert into anti-inflammation. All these immune cells become anti-inflammatory instead of inflammation, persistent inflammation. So let's move into different areas, the micronutrient requirement for the immunity. So here are some examples of micronutrient we are going to need to have the full potential of the immune system. K2 is particularly to prevent negative effects of ionized calcium, to divert ionized calcium into the musculoskeletal system. But B2, A, C, and magnesium are crucially important. Magnesium is important for a number of reasons. For example, hormone release and hormone action, including the insulin, does not work properly when the magnesium levels are low. So magnesium is a lifesaver at the right concentration, including in COVID. And then you get the zinc and selenium. These are antioxidants. And those are very important. In addition, the zinc has got a tremendous effect on prevention of viral cell multiplication intracellularly. And then I have mentioned a few other things like the essential fatty acid and even T3 level is really affecting the total immune function beneficially to boost the immune system. Now I'm going to switch gears to a small area, which is the effect of aging and the comorbidities, how that affected the SARS-CoV virus and deaths. We know that the older people and people with comorbidities die predominantly compared to those who are younger and people without chronic disorders. So here are a couple of slides I'm going to show on that one. So poor nutrition causes vitamin D deficiency, so it's pretty obvious. But aging and malnutrition also reduce the ACE2 concentration, the soluble ACE2 in circulation. Therefore, viruses has a higher probability of dissemination. Now, these are modulated by the comorbidities. There are so many, pulmonary, lung, kidney, and any of those comorbidities have the same bad effects on the ACE2 and vitamin D level. And this can be also modified by the places you're living, the pollution and environmental other minor things it can affect too. So let me show you an example of how age-related mortality affected by affected the SARS-CoV-2 virus deaths. So here we're looking at the age categories and age-specific mortality rate. As you see, again, I'm not sure you can see under this right side block, this highest mortality is those who are above 71 and upwards. So in fact, some studies show that something like 80% of the death occurs in this particular group, although numbers are smaller. So basically it shows that up to about 70% of all deaths occurred in persons occurring older than 70 years. So only 30% occurred in a younger generation. Let me give you one classic example from UK to show that difference between the ethnic groups. Whites and BM stand for the Black, Asian, and ethnic minorities. We do not use that terminology in US, but it's very commonly used in Europe, BME to categorize people with the darker skin. This particular data set shows that those doctors who died work in the same system, in the people with the Caucasian, they died average about 88 years old. Whereas a person with the darker skin color, they died 30 years earlier. So only difference is the skin color and therefore the low amount of vitamin D, because they are doctors working in the same healthcare and national health services system with the same socioeconomic background. So this is clearly highlighting the importance of vitamin D in protecting oneself from COVID-19 like illnesses. Another slide from David Grimes from UK. And here looking at the death rates in the United Kingdom during COVID. So what you're looking at is the number of deaths against a time. So during the summer period, you can see that deaths were non-existing compared to the winter peaks. Why is that? Because there is a higher production of vitamin D and people go out and get sunshine. It's quite common for, like in US and UK, people to go and get sunbathing, etc. Therefore, their vitamin D goes up, infection vulnerability goes down. Therefore, the death rates comes down naturally. This has nothing to do with the vaccines or any other intervention, public health intervention at all. This is the second slide I wanted to show you regarding the age and comorbidities. It's the senior citizens with the comorbidities had the lowest vitamin D levels, the highest vitamin D deficiency. And similarly, they also have the lowest ACE2 concentration. So these are the key risk factors for COVID infection, complication, and death. So in addition to, of course, comorbidities and other things can modify the risk of COVID, but nothing like low ACE2 concentration and vitamin D deficiency. Unless we corrected these two, it's difficult for older people to overcome this infection. The easiest way to ACE2 to go up is vitamin D. Vitamin D has a direct effect on the ACE2, increasing this expression and the synthesis of ACE2, thereby reducing the COVID-19 risk dramatically. Here's an example of what's happening with the pre-existing conditions, what we call the comorbidities. What you're looking at is the age categories against a number of deaths. One in blue is a people with the pre-existing conditions. In the same age group, in red are the people with the no pre-existing condition. You can see, you don't need the statistics, you can see the dramatic less infection and the death rate of the people without comorbidities. So this data, we had that in later 2020, and we did not take action on this. The reason I'm saying that actually these deaths could have been prevented by taking highly focused actions on the older people in residential facilities, nursing home. They are the people who died in maximally during things. Those deaths would have been easily prevented by reducing the comorbidities and giving vitamin D supplement. This is an example of one of those comorbidities, which is obesity. And what you're looking at is and the obesity, increased obesity prevalence here. Similar data is available on obesity on the BMI scale, exactly similar. And here look at the reported COVID deaths per 100,000 population. So when the obesity increases beyond 30 BMI scale, it starts to go dramatically high. It exponentially goes up. So again, as you see that the majority of people died from COVID, in at least this category, you can see that there's no comparison between the people with morbid obesity and those who are not overweight. So what are the relationship between the oral vitamin D and serum 24-hydroxy concentration? Let's quickly have a look at it, because this is also important for fundamentally for treatment and prevention point of view. Currently, the most government recommended dose of vitamin D is about 800 micrograms per day. which doesn't even raise the vitamin D level more than 20, which is not even barely adequate to musculoskeletal disorders. Never mind the rest. Even if you double or triple those, still you are less than the threshold of what you need in the circulation, which is 50 nanograms per mil, for these molecules to enter into the immune cells. So we are fooling ourselves by keeping the levels under this, hoping that we are doing something good to them, which are not. As you also say that even with the 5,000 units a day, which is a recommended dose now, it takes several weeks to months before they achieved the 50 nanograms per milliliter. So in acute emergency like COVID infection, somebody getting infected with symptom, giving 5,000 units a day is a completely placebo. It has no effect whatsoever because it takes several weeks by the time patient is either cured or dead. So in these scenarios, it's crucially important to give a bolus dose, or what I call the loading dose of vitamin D. I'll come to that later, like the 100,000 to up to 400,000 units. There's a couple of milligrams basically, to rapidly raise the vitamin D level so that the immune system can be boosted and they recover themselves because they're having now the robust immune system. So once you raise this serum 25-hydroxy level to this level, you can clearly maintain it with the 5,000 units a day. So that's perfectly okay. Here's an example how do that. So what you see is in blue is giving after 200,000 dose of oral dose of vitamin D. It goes up, but it does not retain. It needs to be retained at least during that critical 2 to 3 week period of the illness, but it doesn't do that. So single loading dose almost always fail, as you have seen that in some of the very large studies published, knowing that it's not going to work. It's a poorly designed studies. They should have known the biology of vitamin D, how it affects the immune system. To avoid that, what is the best way to approach is actually to give calcifidiol between 0.5 and 1 milligram, tiny amount. That will absorb to the circulation directly, increase the serum vitamin D level within 4 hours, above 15 nanograms per mil, and boost the immune system within 24 hours. Nothing like that with any other medication can do, nothing. And not only that, because you're giving with the higher dose of vitamin D as a cocktail, then you maintain the serum level high enough for a few weeks, usually 4 to 6 weeks. That's enough for patient to recover fully. If not, you can give another larger dose to maintain it. So this is a critical part if we were to rescue lives from this acutely ill patient. Giving vitamin D high dose does not work because it takes 3 to 4 days to raise vitamin D. It has to be given with the calcifidiol, very small dose. As I said, for adults, most adults, 1 milligram is more than enough to do the job. So what does vitamin D do to the immune system? It acts both innate and the adaptive immune system. It's very important. It's not only compartmentalized, the total immune system. To do that, we need to maintain the circulatory 25-hydroxy D level above 50 nanograms per mil to stimulate the immune cell. And then they produce antimicrobial peptides and all host of things we don't have time to discuss. And then it also imports the adaptive immune system, which is acquired immunity, for example, after vaccination. But vaccination does not work unless the immune system is functioning. So giving vaccine to somebody vitamin D deficient only make things worse for them. It's a side effect. They will not get benefited. Again, the key point has missed by virtually every leading scientific organization, including WHO. So when you have the adaptive immune system boosted up with vitamin D, it produces many things like a memory cell as well as a neutralizing antibody to overcome the disease. Okay, next let's look at the relation between the vitamin D levels, or 25-hydroxy D level, and in persons with the SARS-CoV-2 infection. The first one is about the SARS-CoV-2 positive rate. It's a PCR-based study by the Kofferman et al. Again, this was published in late 2020. So this information was available in 2022 to make the right decision, but no one took that right decision. So, for example, if you can see that from 30 to 50 nanograms per mil raise of serum levels will reduce the PCR positivity, in fact, the infectivity, symptomatic disease by 50%. So, and many of them will go to the develop complication and attended hospital. This all could have been prevented by maintaining high level of vitamin D with a simple guidance like stay in the sunshine or taking over-the-counter vitamin D preparation. Now, in this particular slide by Samaha et al. Is again a very key, is a key study showing the probability of survival. 1 is a fully survival, 0 is death. So here looking at this concentration depending gradient of survival or death of COVID-19 patient based on vitamin D. Again, I'm not saying that this is the only reason, but this is a key reason for that. For example, if you raise the level from 10 nanograms to 30 nanograms, you can see a 35% reduction of death or 35% increase of survival. So to get into the maximum area, you need to have a minimum of 50 nanograms. There are plenty of studies to confirm this particular set of data. And also important to note that if you push the level even higher, it has got very little effect. So you don't need to have a level of 70, 80, or 90 nanograms per mil, but just above 50 nanograms per mil will virtually fully stimulate the immune system to become a robust immune system. So maintaining the vitamin D concentration about 50 nanograms per mil is the key things to prevent death with COVID-19. So what are the other beneficial effects of vitamin D in COVID and deaths? 2 slides I'm going to show you. One is a risk of infection. This is from it's a fundamentally important study from Qureshi et al. Actually had 2 papers. They showed that when you maintain the level above 50 nanograms per mil, there's no risk of excess hospital-acquired infection. So this is the 2.5 is a background hospital infection. So we actually normalize the infection rate. So when you raise the from here, you can reduce about a third of infection by increasing the serum 25-hydroxy level from 10 to 50. This is a no-brainer. So, but this study was published, as you see, 10 years ago, and fundamental study. Second one I'm going to show over there is risk of death, very similar. So here, what you're looking at, the COVID-19 deaths hazard ratio against the serum level of 25-hydroxy vitamin D. Higher the vitamin D level up to this level, it reduced the death rates. Beyond that has got a very little effect. For example, from increase from 10 to 50 nanograms per mil in circulatory 25-hydroxy D, it reduced the death rate by 6-fold, 600%. Unbelievable. But again, still people ignore this valuable data. The last slide on this section, I'm going to show you about the calcifidiol. Here what you're looking at is the first one is a Trunk et al. Published some time back. And it shows that 4 categories: healthy, mild cases, severe, and those who died, and their serum vitamin D level. Again, you don't need statistics. It's obviously blatantly obvious that the higher the vitamin D level up to a level is beneficial from prevention of death, not only hospitalization. Slide on the right side is about the cumulative distribution of related deaths against the days in hospital. By about day 20, these are the severely ill patients stay in the hospital. By about day 20, 20% of those with a low vitamin D had died, and only 5% of those are acutely died from COVID. So 75% reduction of the death alone by vitamin D alone without any other major intervention. So this slide it's a little older side now, but to show that there have been numerous studies to show that vitamin D relationship with the COVID. Basically, some are the hospitalization. These, I think, is a real-time analysis of the death. So when you look at this, whether whether early treatment, late treatment, or preventative, vitamin D has a key role of prevention of death and hospitalization in this patient. This slide basically is an interesting slide. So if you look at from 20 to 23, actually you can see it's under the right panel. The overall efficacy of the vitamin D hasn't changed at all. So if you give the right doses of vitamin D, you can reduce the death by a minimum of 50%, actually so higher than that if you look at that. They exclude the flood study. Some of them obviously failed, designed to fail some of these studies. So we don't need any other expensive treatment, ICU expansion or hospitalization these patients, provided that we can maintain the decent level of vitamin D in circulation in this patient, thereby reducing overall efficacy, increasing overall efficacy by reducing the death in this patient. So we had that data by 2021, but nothing much happened. Now I'm going to show you a couple of slides related, and this first one is a simplified version for the vitamin D wiki. It's jumping. Now, we know that the prevention is a cure. Prevention is very important. However, once you get infected, start of symptoms, hospitalization, all this complication occurs in those who are with a severely vitamin D deficient, usually in the range of less than 10 nanograms per milliliter vitamin D. Now, this is what really important. That's, if you expand that particular thing, benefit of using vitamin D in COVID, it's actually, you need to give the vitamin D or preventative medication to the earliest possible. Now, giving vitamin D in the ICU patient has got a very little effect because they are already doing all the complication due to virus, and there's nothing much you can do. The late therapies are not that effective. So intervention should be at the time of the diagnosis or exposure to this condition, just like in some other lethal condition. So treatment should begin within this first couple of days. More the delays, the less efficacious of vitamin D, or in fact, for that matter, any other agent. But most importantly, if you begin the calcitriol with vitamin D at the day 1, day 2 of the infection, you don't get into that major negative area. As a rapid and full recovery, almost 99.98 recovery from this infection without deaths. So vitamin D saves lives in persons with COVID. There are so much information on that. So most people with COVID-related complication and recovered or died had a severe vitamin D deficiency. Those who had vitamin D sufficiency had no reason to develop complication or die from it. So therefore, it is quite logical to give what is lacking for these people as a replacement with vitamin D. This is a study from this particular C19early.org, showing that the same thing but on more graphical way. So here what you're looking at is the number of days, and longer the delay of treatment or the having the vitamin D sufficiency for in this case, the higher the death rate in this patient. This is from the C19early.org website. So what are the lessons we learned from the past 3 years of COVID and serum connection to serum 25-hydroxyvitamin D, which is a circulated form of vitamin D? There's a strong inverse relationship between serum 25-hydroxy concentration, the risk, infectivity, severity, and death from COVID. There are multiple studies published on that one. So in general, the outcome-based studies has showed that asymptomatic disease happening with the people with the 15 nanograms per ml, they don't even develop complication. They're PCR positive and they recover. And then the mild disease here, and the moderate disease is 20 to 30. They do develop symptoms, sometimes need hospitalization, and others, the lower, those are the severe vitamin D deficiency, are the ones who get into trouble and need hospitalization. The quickest ways to boosting the immune system in these acutely ill patients are the calcifidiol. With a partially activated vitamin D, it does not need to go through the entire cycle of activation. And for example, if you give it between 0.5 and 1 milligrams of calcifidiol, it acts within 4 hours very quickly. And the dose is 0.014 milligrams per kilogram body weight. So act within 4 hours, and it boosters immune system up. And what we need is to maintain the minimum serum 25 hydroxy level above 450 nanograms per ml to get the maximum benefits. So here are a couple of ways to boost the immune system in this scenario related to COVID. You can have a combined calcifidiol and vitamin D. This is a partially activated vitamin D, and vitamin D is a parental form, and admission at the earliest sign of the infection. So calcifidiol will start acting within 4 hours, and vitamin D take 2 or 3 days to act because you have to get activated in all these scenarios. So this kind of protocol will save lives, prevent the need of hospitalization and the ICU use. So in not obese patients, this is probably good enough dose to overcome the COVID infection. However, the obesity 1 and 2, BMI up to about 40, need a higher dose of vitamin D because it gets sequestrated in the fat tissues. They need higher doses. And those with obesity 3 require much higher dose of vitamin D to overcome the viral infection, particularly COVID. So let me give you an example of comparison with the cost effectiveness. These antiviral agents, these are cost about $700 per patient treatment, and they're effective about 50% in preventing hospitalization. Vitamin D, or for that matter, ivermectin, is cost about $2. So therefore, nobody wants to know about it. It's too cheap. But it has even 70% or more higher efficacy of reducing hospitalization. So what are the other cost-effective generic agents available for use in these scenarios as adjunct therapy to prevent complication and death? Vitamin D, calcifidiol, ivermectin, and there are a whole bunch of things actually published in the website, and all has got their own niche areas to help the patient to get over the complications. So early therapy is the best option, no question about it. Longer you wait and longer you wait to develop the complication, harder to recover the patient. Effective of some of these generic agents are in fact better, like vitamin D, than the patented expensive generic drugs. Rarely there's one treatment is available for one disease. Therefore, you need to have sometimes combined diseases. Although vitamin D is not a medication, it is a supplementary to many other medication one can use. Not everyone responds to one medication. Therefore, adjustment of the dose and the combination are necessary. So we need to take time and listen to patients, provide unbiased advice, provide options to patients, including vitamin D, and many healthcare professionals don't do that yet, and let the patient decide what the best option to do for patient to move forward. Vitamin D is a cost-effective additional or adjunct therapy for infection. It's not a treatment for SARS-CoV virus or any viral disease. It's simply improve your immune system to act against the viruses, particularly. So vitamin D should not be used alone. It's administered in addition to the standard recognized antimicrobial therapy. So it's an adjunct therapy, but it's very potent adjunct therapy if you use early enough and the right doses. And with first-line medication, as this I mentioned before, vitamin D can boost the immune system, thereby improving the patient condition quickly. So in summary, there's a strong inverse association of serum 25 concentration and COVID severity and death. Better the vitamin D status, lower the complication and the risk from COVID. Taking 5,000 units international unit per day will maintain the healthy serum 25-hydroxy level, maintain the robust immune system. However, it's completely inadequate in the acute situation. As I said before, you need a few 100,000 vitamin D as a bolus dose to overcome the boost the immune system. So in emergencies, the loading doses between the these are very important to boost the immune system too, so that the patient can recover themselves through their good immune system. So there are certainties, there are uncertainties, but the truth is science is continually changing, it's evolving. So truth is not changed, but the science is changing. So sometimes we are behind the science to achieve the truth. So eventually, truth is going to prevail, and we should be able to, as a healthcare provider, we should be able to provide the better services for the patient. So vitamin D deficiency induced disorders are common. However, many of these, almost all of these are preventable. Maintaining the level about 50 nanograms per ml is really important for infection, like viral infection, to prevent complication and death. So in summary, prevention is much better than the treatment. No question about it. So after the musculoskeletal system, vitamin D has a lot of unknown so far for many benefits of the other system. What we discussed today is its beneficial effects on the immune system, and the cost benefits of vitamin D exceed hugely. So this is a micronutrient, it's not a medication. So there's no need to legislation or control the drug to vitamin D. Since a micronutrient, it should be available over the counter, but you need to educate to take the right dose of vitamin D at the right time. Thank you for your attention.
Wow. Thank you, Sunil. That was an outstanding overview. I'm sure everybody has a really good understanding now on vitamin D in COVID, vitamin D for promoting health, vitamin D for cancer. So time is kind of up, but maybe, Betsy, we have one or two questions we can answer.
Well, we do. I hope you can stay with us for a couple more questions, please. Yes. We have a question from someone on Rumble, wants to know, is vitamin D at level 87 getting too high for daily supplementation?
The short answer is no, because the people who do not develop adverse effects of vitamin D unless it exceeds 150 or 200 nanograms per milliliter. I know a lot of my physician colleagues, they are maintaining their level around 125 nanograms per ml, way higher than I would like to. And I'm not recommending that, but at 80, absolutely no, I don't think any risk, any studies have shown that any risk of vitamin D causing problems at 80 or even 100 nanograms per ml. But
Great.
for the precaution basis, we try to keep the vitamin D level reasonable, as I suggested before.
All right. We have Christy asks, I take vitamin D3 supplements with no problem. As soon as I add K2, it causes an anxious feeling. I'm thinking it's the MTHFR issue. I'm using a high quality vitamin D3. My question is it okay to take D3 without taking K2 with it? Or does that cause calcium buildup in the arteries?
Yes, it's depending on the dose of calcium, dose of vitamin D taking. And also remember that there are individual variation from person to person. So giving one particular level, it could be misleading. It's a broader group. For example, like A to B, that area is safe. So it generally does not causes that. So the issue is the hypovitaminosis D will not develop until the level goes up very high. And usually this is by the accidental intake. I've seen some which have taken 1 million units accidentally on a daily basis. No wonder they have, 1 month time, you can even measure their level exceptionally high. Those are accidental and sometimes overdoses happen. But taking the general recommendation of vitamin D is really is harmless.
All right, we have another Rumble user, Park Barrett says, I have osteoporosis due to leukemia treatments. Is there a vitamin D, calcium diet, exercise regimen that can help my bones? Standard pharma drugs appear to have horrible side effects and don't seem to work well.
But yes, it's a great question. Actually, in that kind of scenario, it's crucially important to keep the balance of calcium in the body, not vitamin D itself. So higher the calcium, we know that absorption of calcium goes up to a certain level and then started to plateauing off. But everybody doesn't have the same threshold. So some people do have a problem with a lower threshold. So that is not common, but I have seen that happening. So getting into moderate doses of vitamin D, like what you're mentioning in the presentation, is pretty harmless, actually. Longer term, if you're taking very high doses for no reason, except there are actually, let me withdraw it. There are exceptions like intractable migraine and sort of these people getting very high doses on a short-term basis, like 50,000 daily. But that must be done under medical supervision. Do not recommend to anybody to do on their own. It can get into trouble. You need to adjust the dose properly. But the generally recommended doses, really, you can have any issues.
And we have Hervik asks, any relationship of vitamin D deficiency with high blood pressure?
Yes, it does. It does. That's not a direct relationship, and we know that it's dealing with the calcium, intracellular calcium. So we know that when calcium goes down, your blood pressure goes up. So vitamin D is necessary to maintain the calcium level. Therefore, with a low calcium, the blood pressure tend to go up. So vitamin D helps normal doses to maintain the serum ionized calcium and thereby the maintenance of good healthy blood pressure.
Well, those are the ones that I have. Paul, do you have any more questions you want to ask? This has really been a thorough and deep explanation. I will never again forget to take my vitamin D. I take my 5,000 IUs a day. Occasionally I've forgotten to take it. I'm not going to forget to take it again, ever, 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 after listening to this.
I just want to thank Sunil. I think he did an outstanding job, and I think it emphasizes just how important it is for everyone to take vitamin D. And so the other question to Sunil is, if you go into the sun to try and make vitamin D, it doesn't make any sense to put on a sunscreen because that screens out the ultraviolet B. And many of the sunscreens are carcinogenic in themselves. So it is would you agree, Sunil, it's a futile exercise to go into the sun if you put on sunscreen?
It's a deep question. You ask multiple questions within your question. So if you're taking the reasonable dose of vitamin D, as I say, that around 5,000 to 7,000 or 8,000 a day unit, there's no reason to have a sunlight to generate vitamin D, because because body will not produce the appropriate amount of vitamin D. It actually shut down the conversion from vitamin D. So up to a level, unless you take massive amounts, it can override the situation. So the second issue actually to sun itself, sunlight is good, but not many people can get that sunlight-based vitamin D, unfortunately. Multiple reasons. For example, people like me, as a darker skin, I had to wait more than an hour in the sunlight to get vitamin D. And others, people living in the northern latitude, only during the peak of the summer you can generate vitamin D. And you have the sunlight, beautiful sunlight in January. Guess amount of vitamin D produced? 0. there's no UV rays coming at the right angle to penetrate the skin. It does not penetrate the skin. So skin is unable to produce vitamin D. So getting sunlight at inappropriate time, like a winter, is nice to be outside, but it does not produce any vitamin D.
I once got a sunburn skiing in January, but I wouldn't get any vitamin D, just got miserable.
No.
Is that what it was?
No, because the UVB won't get in. You get burned by UVA and other components of vitamin A. So you get all the baddies, but not the goodies.
Okay, we have one more question came in. Do vitamin D creams work?
Answer is I don't know. And the data available with the cream and absorption is very variable. I won't trust that. It's much cheaper, controllable, taking just a supplement over the counter. Take what is the number you like?
I would agree with that, Betsy. I think the absorption to the skin is unpredictable, and so
very
one
unpredictable.
really doesn't know. So, and taking it orally is so safe and effective. So I don't think there's any reason to give topical vitamin D. A good question, but I think that's the answer. So Sunil, thank you for a most enlightening discussion. Hopefully we'll generate lots of discussion. And just for the viewers to know that Sunil will kindly make a PDF available of his talk so that people can review it after the fact. Thank you.
Wonderful. Thank you. Thank you so much. Very, very valuable information. And thank you for doing it when you're having throat issues. You came through fine, but very glad you showed up under those circumstances. Very, very much. And Paul, always great to see you. I have a few announcements for the rest of you folks at home, because one of the things you need to know is, there was a lot of information in this talk, but you'd like an easy way to remember the importance of vitamin D and how to take it, because it's just too much to take in to remember. The help is here. Happy to tell you that. We have a new infographic and a new Substack all about vitamin D. Visit the links on the slide or go directly to our Substack or our FLCCC site under Tools and Guides to find this information. And remember, share it with your friends and family too. Now then, next week's webinar, it's going to be a big one. Our own Dr. Pierre Corey will be joined by special guests, Dr. Brian Hooker and Dr.